Today we have two specialists coming to us to talk a little bit about how we can safely reopen and when to close back down, how to keep your controls in line. We have with us Rafi Sassa, who worked most recently for the Bayer Corporation in the last 25 years. He'd also worked for Boeing and US Steel and many other places in the health and safety arena. And I'll let him give you his own credentials a little bit more as well. And we also have Frank. Frank, I'm going to need you to say your last name. I just realized I don't know how to say it.
Krivka. I've had that issue all my life. So.
Yeah, I have one of those last names myself. So Van Heitzma. My name is Yvonne Van Heitzma. I work with the Bayer Center for Nonprofit Management and the Covestro Center for Community Engagement. Frank and Rafi have stepped forward to also be of help through the Executive Service Corps, where we need help with any health and safety and industrial hygiene. That's a word we don't hear often in the sector because we don't think of ourselves as industrial, but we do have needs that require safety and health of our employees. So it's something that we need to continue to keep in our minds. Frank has come most recently, worked for the University of Pittsburgh in the safety role, and also has many years of experience in other industries as well, or companies. So welcome, Rafi and Frank. We look forward to having you with us today. We're going to use the chat feature for questions. Feel free to chat them at any time, and I will interrupt them as we need to. You can also use your raise hand, although I may or may not see it because we have 40 some people on this call. So feel free to just chat something in the chat window. It'll be easier for me to see. Okay, all right. I'm going to hand the mic to Frank.
Okay, good morning, everyone. It's a pleasure to be with you all this morning, and I hope we can impart some good information to you about getting back to work, and a little bit maybe some little anecdotal things about the virus maybe that you haven't heard of, and sort of all putting it into perspective for us all going forward. I guess we're entering, it's about 4 months now that we've been sequestered, in different ways through the years and through the months. And what I'd like to do is to just head it off too with an idea that what we're giving you is what we know of as of right now. And over the last several months, things have changed quite a bit. Things that were stated back in March, have reversed themselves, and so we'll hopefully get through that and maybe eliminate some of the confusion. Now, as Yvonne mentioned, last 22 years or so, I've been at the University of Pittsburgh. I retired about 2 years ago. I graduated from the university back in 1973 with a degree in biophysics and microbiology, and through the rest of my career, sort of dabbled in using that micro degree. Did marry a microbiologist, so that's I guess is about as close as I've come to using my microbiology and sharing stories of hospital-acquired infections and on all those things over the last 40-some years that we've been married. So I think I have a pretty good background in virology and microbiology, and hopefully I can impart some of that to you as well. As Yvonne mentioned, I have previously worked in the air pollution business for Wheelabrator Fry, US Steel, Koppers Company, and an engineering consulting company, SE Technologies, prior to coming to the university. While I was at the university, I did manage to get a couple of the degrees. I have a master's in industrial hygiene and also a doctorate in higher education administration. So my time at the university, I think, has been pretty well spent. Okay, as I mentioned, a lot of the information we're going to be talking about is what we know of as of right now. And Yvonne, can we see the slides? Hopefully you all can see the slides. I can't. There we go. Yeah, the next slide was where we'll start. This is the introduction slide, so we can go one more. The goals of this presentation are a number of things. Yvonne mentioned to me yesterday that many of you have a pretty good understanding about some of the basics, so a lot of this stuff we can skip through rather quickly. But the goal of this presentation today is to protect you and your employees as you return to work, if you haven't already. And also in doing so, protecting the employees, protecting your families and the general public as things get back to the new normal, if they ever do get back to the new normal. We'll be talking just a little bit about the coronavirus, where it came from, and some of the terminology, that's just so we're all on the same page. And we'll talk about quite a bit about the risk of getting the disease going forward, and and talk a lot about getting back to work safely. In one of the important issues we'll be discussing, Rafi will be talking a lot about, is a pandemic preparedness plan that each company needs to prepare so that we have good information and are able to further lower our risks going forward. So next slide, please. One of the poll questions that we wanted to ask, I don't know if you can pull that up, Yvonne. One of the, just to get an idea of how many of you have personal experience with the coronavirus. I know I've met a lot of people over the last many years, and I really only know one or two people personally that have had any impact of the coronavirus, either with themselves or in their families. Now, you know, a lot of people know somebody that knows somebody that knows somebody, but, you know, individually, not so much. And I could see, okay, quite a few of you have some real personal experience with the virus, and fortunately, even less of those have been hospitalized, is a good thing. And that's one of the things we're finding out, that less than half of the people that have tested positive have actually had any symptoms whatsoever of the virus. And not less than half of you have opened your workplace since this all started. So this is a timely talk, then, getting back to where we need to be. Okay, just a quick recap of the coronavirus in the name of it as well. The coronavirus sort of got its name because of under an electron microscope, the image of it has a thing around the outside we call a corona, similar to during a solar eclipse. You could see the actual image of the sun as the moon passes in front of it. So that's basically where it got its name. Now there's probably many, I think what I heard, one number was 40 species of coronavirus out there. 7 of them have had some impact on human health. The common cold in one or two of the viruses that have affected humans have symptoms similar to a common cold and nothing worse. The disease that we're talking about right now is called the SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome. And 2, as back in 2002, 2003, CoV-1 happened. That was the SARS virus that happened over in, I guess it was in the Middle East. We'll talk a little bit more about that later. But when we're talking about the virus itself, We have the SARS CoV-2 or CoV-1 going back, but CoV-2, that is the virus itself. Now, what we're dealing with the pandemic is called COVID, coronavirus disease 2019. So that's basically where we're at with the name. So I know some people were somewhat confused and they used the terms interchangeably, but that's what it is. Okay, the originations of this, but what we know of now, apparently it started in Wuhan, China, from the source of bats. This is the most common story that we're getting right now. And from bats, and it happens so many times, bats, many species of bats carry viruses. They don't get sick with them. They don't have any symptoms of the disease, but they can easily pass the virus along to others. In this case, it came through an anteater and then passed on to humans. Other species of animals have been tested to find that they do have coronavirus, and including dogs and cats, again, without having any symptoms or passing those along. I know they killed a lot of minks over in Scandinavia that were tested positive for coronavirus, and the fear of them passing the disease on to humans resulted in their being put to sleep, prevent that spread. And that same thing happens a lot with the flu viruses, with the avian flu viruses. You've heard stories about how many thousands of chickens have been disposed of, or even swines with the swine flu viruses that have been popping up. Rather than risk giving them to other humans, they put the animals to sleep. But with COVID, that's the story right now. There is two, I just read last week, there were 2 World Health Organization investigators that went to China just on July 10th to meet with the experts in that virus research center to try to come up with, trace back to where the source of this virus is. So that story may change going forward. So, but what we have right now is the transmission from bats to the anteater to humans, and through the wet thing. Now, these are some of the symptoms that everyone's sort of aware of initially. That whenever you got sick, people said, first watch out for fever. Some people had fatigue, and then shortness of breath were the 3 most common things that sort of tip people off that they had acquired the virus and should seek some kind of medical attention. And you can see the other symptoms there. And as things get worse, the kidneys, the pulmonary system, and eventually pneumonias can all happen. So those are the more severe symptoms that people have. Next slide. Okay. What we're learning about right now, apparently the median incubation period is about 5 days. So from the time you're exposed, the average incubation before symptoms, anybody gets symptoms, is like 5 days. Now it has been as quick as 1 day and up to 14 days, and that's where we come up with one of the periods, the isolation periods of 14 days. Now that's since changed, and Rafi will get into that. And even as little as people do show fever, maybe test positive, if they haven't had any symptoms in 3 days, a lot of times they're considered to be safe enough to resume normal activity. So, and of course, keeping an eye that the more symptoms will be coming forward. Now, the most likely source of spread of the virus from person to person has been through the respiratory droplets. And when you cough or sneeze, someone close to you is exposed to those aerosols and get them in the back of their throats. Potentially, they can become infected. And we'll talk a little bit more about how frequently it happens and what some of the thoughts are on Certainly not everybody that gets exposed is infected, but certain people that are more prone to that certainly can be. The virus is also detected in feces. So, and like many viral diseases, the spread is from hand to face or mucous membrane contact or hand to food and ingestion. And there's some thought that this is a major source of spread of the coronavirus as well, although certainly the aerosolization is one of the main ones. So therefore the mask and the social distancing are the things. Now, you know, the mucous membrane spread through the mouth, through the eyes, through the nose. Any of those can cause the virus to enter into our bodies. Certainly with any viral disease, you need to have the proper or sufficient dose. One of the adages of industrial hygiene came from a gentleman known as Paracelsus. That was his nickname. He's some German fellow back in the 16th century. He claimed that the dose makes the poison. So you can be exposed to many toxic things, including infectious agents, but unless you have a sufficient dose, chances are you're not going to be harmed by that. So, and that's very true with the coronavirus. You know, 10 viruses or 100 viruses, if they happen to get into your nose or the back of your throat and infect your lung tissue, they have to get down into the lung tissue because that's the cells in the body that they attack. So if they don't make it down to your lungs, to your lung tissues, chances are you're not going to get sick, even though you might have been exposed to the virus. Now, it may take 1,000 or 10,000. We really don't know the number, but it takes a sufficient dose before people get sick from inhaling or ingesting or touching their eyes or whatever with the virus. Now, there's been a lot of controversy about these aerosols when they get on surfaces. Is that a possible source of exposure? With many viruses, certainly flu viruses and things, you can touch a surface or somebody's sneezed on a surface, you touch that surface and touch your eyes or get it into your body through the mucous membranes, you can be exposed. There is some thoughts that this coronavirus spreads that way as well. What we don't really have a good handle on is how long it survives on a surface. I've heard numbers anywhere from a few minutes to days to weeks, and going forward we'll talk about that. Next slide. Next slide. Oop. Okay, so one thing we do know is once the virus leaves the body, okay, it's starting to die. Viruses aren't living, so they really can't die, but we'll say that they die or become inactive, okay? So once the virus is sneezed out of the body or coughed out of the body, it's already starting to die. And okay, it's in a droplet that has maybe some materials that it can survive longer, maybe a day, maybe 2 days. But once that droplet falls onto a surface, if it's a porous surface, it'll probably die or become inactive more quickly. If it falls on a surface where there's a lot of moisture, it could probably survive longer. If that droplet nuclei evaporates, that virus is going to die real quickly, particularly in sunlight or in real dry conditions. So humidity, temperatures, a lot of those things play a big role. The hardness of the surface. Now, some of the early reports that we heard about where people, you know, swabbed the surface a week later and found that there was viral proteins on that surface, that was true. The virus dies, but the proteins are still there. The same thing happens with mold or bacteria. Once the organism dies, the proteins remain, and that's really what they were testing. So they swabbed the surface and they found these viral proteins, but there was no way that they could tell whether the virus was living or dead at that point. Chances are it was dead. So that led to a lot of confusion where the people were, you know, bringing home bags of potatoes and dumping the potatoes into their sink and scrubbing each one with soap and water to get the virus off, or leaving their grocery packages outside for a day or something before bringing them in the house. I know my daughters had gone through that for a while, and then gradually they realized that after a few minutes or a few hours, that wasn't a real significant source of exposure. So some of those practices have eased up quite a bit. So I think we can all take heart that the virus dies pretty quickly. In general, this virus, the coronaviruses are relatively easy to deactivate, not kill, but deactivate since they're not alive. And this is because it's called an envelope virus. It has a lipid coating that's very easily penetrated by soap and water, and also by any one of the 400 EPA approved disinfectants, the alcohols, the bleach solutions, quaternary or ammonium compounds, you name it. Many of these disinfectants will deactivate the virus or inactivate the virus. So it is relatively easy to kill. So until this the virus gets into your body, it's not going to survive too long in the environment. Now, once it gets into your body, our bodies are very good at destroying foreign invaders. And of course, you've all heard about antibodies and your immune systems, immune cells, the white blood cells, and of all different types. And what these antibodies or your immune cells do, you saw pictures of the virus with the spiky things coming out of it. Well, those are the protein sites where they bind to the lung cells. And anything you can do to destroy those protein spikes with antibodies binding to them, inactivating them, or binding up those sites, or if your lung cells have enough the right type of coating on it or whatever, those spikes can't attach to the cell. Therefore, they don't inject their RNA into the cell to allow the spread of the virus. So, and that's what many vaccines do. They do tend to disrupt the process where the virus gets into the lung cells, and where they in a process called reverse transcriptase, where they take the cell's DNA and make more RNA, which is what this virus consists of, with the protein coat. It disrupts that reverse transcriptase process, and that's how the replication of the virus is defeated, and that's the goal of vaccines. Just a couple of statistics, and of course a lot of these are changing even as we speak. But so far, it looks like about 81 cases of the COVID disease are mild. Okay, people get the disease, they may get a fever, they'll feel fatigued for a while, they may develop a cough, and they can be infectious to other people, but they might not be, depending on different factors. But most of them recover very easily without any hospitalization. And looks like it says here, 14% of those infected require hospitalization. And I guess this depends too on how busy the hospitals are, whether they'll want the person. Initially, when you called in, said you had these symptoms, they said stay home, and it really didn't give you any good guidelines as to how soon you should come to the hospital. They said, well, if the symptoms get worse. But in some cases, these symptoms got worse so fast that by the time the person finally went to the hospital, it was too late for them. Again, this is a pandemic. There's been several pandemics in recent history. Certainly going back over the eons, everybody's been talking about the swine flu of 1918, certainly, but more recently. I mentioned the SARS in 2003, and you could see how limited these were. In 32 countries, about 8,000 cases, some 700 and some deaths. The swine flu of 2009, now I was involved in this. I was at the University of Pittsburgh, and we were involved in vaccinating a lot of students and tracking patients and isolating students that got sick. They set up separate dorm rooms for a lot of these folks and delivered meals to those rooms and stuff. But worldwide, about 1 billion people contracted the swine flu in 2009, and about 400,000 or so those cases died. Now, these are what we were suspecting was going to be the mortality rate, less than 1%. And we're hoping it's a little higher right now with COVID-19, but we're hoping that number drops. Now there was another coronavirus in 2012, 2013 called the MERS, Middle East respiratory syndrome, and that was it came out of camels supposedly, and it infected quite a fewer people in the Middle East, like 2,500 people, and quite a high mortality rate with that. But one thing I want to mention with these coronavirus diseases, initially there was thought that, well, this virus is just going to die. Okay, over the summer it's going to go away. That's kind of what happened with SARS and MERS. They just kind of disappeared, and that was thought that was the same thing was going to happen to the COVID-2 virus, but supposedly, yeah, it's hanging around. Now, one thing it's interesting to note with any parasite, okay, and a virus could be considered a parasite. You're not a very successful parasite if you infect your host and you kill every one of your hosts. And what happens, the parasite cease to exist. And that's kind of what happened with SARS, COVID-1 and MERS. A successful parasite, infects the hosts, it sickens the host, it allows the virus to replicate many, many times, but it doesn't kill the host. So it continues to spread, and it spreads throughout the population, infecting many millions of people, but it doesn't kill most of them. Okay, so the virus can exist for a longer period of time. And that seems to be where we're at with this coronavirus. So hopefully we'll get the vaccine, we'll get some treatments for it that seem to slow the spread of it, that they were able to deactivate the virus in the individuals, and they can more easily recover until we have a vaccine that can't control that. Now, to get it to the very end of its existence may take decades. Even some of the H1N1s, the flu viruses, they're all surviving even to these days, even with the vaccine. So vaccines aren't necessarily 100% effective, but they're pretty good. Now, this slide, I just wanted to point out that with many of these viruses or bacteria, and these are all viruses, but what happens is each person that comes in contact with another person can infect other people. Okay, now with COVID-19, it looks to be somewhere between 2.5 and 3. So each person that comes in contact with a person, they'll infect up to 2.5 or 3 people, and that's pretty good. But compared to some others, like the earlier SARS virus, and it infected 10 people. The MERS virus was really an active thing. It infected up to a whole lot more people. You could see that the fatality rates with some of these were pretty high. Now, go to the next slide. This will be a better explanation. We're talking about the RO values. Next slide. Nope, back up. There you go. So just, well, there you go. Okay, COVID-19. So each person that's infected can infect up to 2.5 more people. With the earlier SARS, it was 3.5 people infected. With some of the more common things that we're familiar with, mumps. If you have mumps, you can actually spread the virus much more readily. 4.5 people. Rubella, measles, 6 people. Smallpox is about the same. Each person with smallpox, the spread of it was like 6. Now these are based on statistics over many, many decades. Now one of the worst ones is measles. You can see how quickly measles can spread. So this is why a student in a grade school or high school gets measles, or a college gets measles. It can spread quite rapidly. And so on for the vaccines. That's why everybody has to be vaccinated against measles and smallpox and mumps and so on. And once we get a vaccine for COVID-19, it would probably behoove us to get everyone vaccinated, as many people as possible. Okay, next slide. Now, one of the things we wanted to focus on was the hierarchy of controls. Okay, and this is a very important concept in industrial hygiene or occupational health, and it shows that the main focus should be on elimination, substitution, engineering controls, administrative controls, and at the very least, personal protective equipment. Now, so far with SARS, we've pretty much dabbled in some of these things, but initial reliance, and as it is with many new illnesses or chemicals or whatever, the first reliance is going to be on PPE, because that's the cheapest and easiest thing to do to protect people. Okay, and I can't say it's wrong, but the focus should really be up at the top, eliminating, substituting, and the engineering controls and administrative controls. Now I'm going to walk through some of these, and I think Rafi will get into this more as we get into programs and developing programs for coronavirus. Next slide. Now, elimination with this virus is probably going to be pretty impossible because with any virus, we don't really know where they came from, where they started, how can we control it. Certainly, animal research and learning more about viruses and studying bats and all those things can help us to eventually eliminate many of these viruses from our world. Vaccine research, very important. I mean, certainly somebody would say, well, let's get rid of all the bats. And certainly that's not a good idea, even though they're probably the most likely source of viral infections. We can't kill the bats. Could we ban the wet markets where this virus spreads? It sounds like a good idea, but in China and many countries, those are pretty important. Could we eliminate the spread of those? Now, one thing it's likely, and this is still a controversial thing, did that virus come from some careless virus research in China or elsewhere? And this has happened in the US. I know at university, communities, we've experienced that, where somebody gets a little lackadaisical about handling a very dangerous virus in their research lab, and they expose people. People have been sick and people have been killed around the country working with some very dangerous viruses. So you need to do that. And then finding the vaccine to eliminate the virus from existence certainly is one goal, but going to be tough to reach. The next level, substitution. Substitution. There are less serious strains of virus that we could work with. Some studies are using on like disinfectants and things like that. There are some of you could actually buy some of the other coronaviruses and buy cultures of them to use those in your research to study disinfectants and how things spread. So it'd probably be a good idea to use these less virulent strains to do that kind of research. Limit the wet market sales to animals that aren't prone to virus spread. Now, one thing I didn't mention with this coronavirus, it seems to be mammalian cells, mammals, so fish and things like that, and birds. It doesn't seem to go there. Could we ban virus research until vaccines are available? And always look for more effective disinfectant materials. Next slide. Probably one of my favorite ways of controlling any hazard is through engineering controls. And these are, one and done. You put up the engineering controls and you can control that. Now, one thing we have to find out with the coronavirus is, are these effective? Are they making things worse? One of the things would be upgrading biosafety levels in virus research labs. Initially, when COVID-2 came out, it was considered a biosafety level 2 virus, which meant that it wasn't spread through aerosolization. Well, we know that's not true. Now, anybody doing research with COVID-2 is doing it under biosafety level 3, which involves cabinets that capture all of it, so none of the virus gets out into the laboratory. Testing methods, we're still working on getting better testing methods. They have some instant tests, but finding out that they're not 100% accurate. We're getting better with that, and hopefully the analysis is taking shorter times. Initially, it was 5 to 10 days once you had a test before you find out whether you had it or not. So UV lights, there's a lot of focus on UV lights. We don't know how well it kills the virus. It probably could be effective, but you can't put UV lights everywhere because of the hazards of UV lights to the eyes. And so you can't just put UV lights all through the workplace. Now, can you put it in our air handling systems with safeguards for people that might have to, maintenance guys that might have to go in there? That could work. You've seen a lot of the ads of people walking around with backpack fogging machines. I think Stanley Steamer and a couple other places are making their business grow with these fogging machines, spraying disinfectants, hydrogen peroxide or alcohols or things like that around. I'm doubtful how effective those can be, and are they realistic control measures. One of the things that we've seen a lot of is these plexiglass face shields at every checkout counter and so on like that. And yeah, if somebody coughs and that plexiglass stops the cough or sneeze, yeah, but the same thing would happen with a face mask. And the other thing you have to worry about with these plexiglass face shields, and fire marshals are starting to become aware of this. If a building has a sprinkler system and you put up a plexiglass panel, that sprinkler isn't going to reach the areas it's designed to reach if there was a fire to break out. Or the other thing is the ventilation systems are designed without those plexiglass shields. So if the area that you're working in isn't getting the proper ventilation, that could actually be a worse risk for the virus. So those things all need to be considered. Social distancing, actually you can call that an engineering control. The lines on the floor, the circles on the floor all have that impact. Next slide. Okay, administrative controls, that seems to be a lot of focus on that. And you can see the things there about limiting the number in the workplace, have the social distancing rules established, develop a program, cleaning, break room habits, having people work from home, having people, have sick leave policies or things like that to allow them, taking the stairs instead of the elevators. One tip somebody gave me was, you carry a golf tee in your pocket, and if you have to push elevator buttons or some other buttons, push it with the golf tee and then throw the golf tee away. So hand sanitizers, all those kind of things are all some of the administrative controls that we're all used to hearing about, and probably we'll be seeing those in all of our programs going forward. Next slide. Now, supposedly the last line of defense is, next slide, okay. This is, again, some of the administrative controls. Now, one thing about, just evaluating how effective your cleaning is or how effective your hand washing is. There's a product called Glow Germ. Maybe many of you have heard about it. They do this with kids, and they have to wash their hands, and then they put Glow Germ on their hands, they wash them again, and then they shine a UV light on it. And you can see how poorly they use the Glow Germ. Now, these have been used in hospitals to evaluate how well the custodial staffs are cleaning surfaces. So you can conceivably use this in your lunch table or coffee pot or whatever, put Glow Germ on those surfaces, have people clean it and then touch it and then see if the Glow Germ still exists there. So it's just a fun test that people can try to see how well their cleaning practices are at that. Next slide. Okay, personal protective equipment, the last line of defense. Of course, this is the focus of a lot of the COVID controls. Face coverings, masks, N95 masks for if you're doing treating patients, like in hospitals, N95 masks are the rule. If you're treating a person that comes into the ER coughing, you have an N95. If you're doing a respiratory procedure on a person, you have an N95. Face shields or goggles to keep the virus out of your eyes, good idea. Protective gloves, okay, in a hospital, probably not practical for the general public, although if you're a food handler or something like that, protective gloves probably aren't a bad idea. And if you're into the cleaning practices or something like that, where there's a known virus infection or virus contamination, protective coveralls are another means of controlling those exposures as well. And next slide. Okay, I just want to close with this slide, and there's the link down the bottom you could take a look at down the road. There was a study done. People were talking about all different kind of face masks, and there are all kind of things shown out there. But the Florida Atlantic University researchers did a study and they visualized how far a cough would spread. They were able to focus on the spread of a cough or a sneeze. And with no face covering, they came up with about 8 feet. That cough spread out that far. With a simple cotton bandana, like a cowboy bandana, and they coughed into it, it still went out 3 feet. A loosely folded fabric mask, just the simple mask that you fold fabric and tie it around your face. The fabric, the spread went out about 1 foot. The commercial surgical masks, the blue masks or yellow masks or whatever, it actually controlled pretty good. It went out about 8 inches. And one of the best ones they found were these the commercially available masks with multi-layers, sometimes 3 layers. Coughing into that, the spread actually went out about 3.5 inches. So masks of any type can control the spread. The fabric of the mask is important. It just depends how easy it is to breathe through. Can you wear it for an extended period of time? Is it washable? That kind of thing. So, okay, that's where I'm going to leave it and turn it over to Rafi. He's going to go from here down to through the rest of the program. And afterwards, if there's any questions, certainly we can address those in the question and answer period. Okay, thank you.
And again, I think part of it is really understanding the virus so that we know how to control it. So thank you, Frank, for helping us, again, continue to understand what we know about this virus keeps shifting. So thank you. All right, Rafi.
Hey, mic on for me?
Yep.
Okay, good. Again, my name is Rafi Sessa, and a little bit on my background. I've got a bachelor's degree from Pitt in biochemistry and a master's degree in industrial hygiene and environmental science from Drexel University in Philadelphia. And I spent as Yvonne had mentioned, I spent most of my career working for Bayer, about 25 years. I ended up the last 10 years as the corporate manager of safety and health for Bayer Corporation and then Bayer Material Science. Prior to that, I was with PPG, an environmental consulting company nationwide, and I spent some time with Boeing, and I spent some time at the Bettis Atomic Laboratory in Pittsburgh, and then the last 11 years I've been doing part-time consulting business in safety and health, and most of my background is occupational safety and health. So that's where I've come from. And what we're going to try to cover now is taking some of the information that Frank mentioned and see how it needs to be applied to developing and implementing preparedness plans. When we started with all of this, in reopening businesses, the CDC, Center for Disease Control, had established some recommended criteria for being able to reopen. And they were looking for basically 14-day periods of downward trends in illnesses, COVID-19 illnesses, downward trend in symptoms, downward trend in cases, less positive tests as a percentage of total tests, trying to get a handle on how to control the exposures within hospital and nursing homes. But we found historically, or recently within the last month, a big spike in cases across the country. And I don't want to point any fingers, but the problems with that either stems from states reopening too quickly and not following this criteria, or states not having that many cases in the early phases of this in March and April and early May, and then looking to reopen, figuring that they didn't have much of a problem, and then not establishing rigorous enough protocols for and requirements for reopening. But what I can see in all of this is the control measures as they apply to what you would put in your own preparedness plans are still dependent upon how well the control measures the states have established to limit the overall spread of the COVID-19 disease. Because when people come to work at an organization, you can put controls in place, but if they leave work or leave their activity with your organization, they can go to places where they can pick up the disease and potentially bring it into the organization and potentially compromise things. When we talk about pandemic preparedness planning for going forward, and I understand from the survey, a majority of you have plans in place and some don't. So maybe what we're talking about here today might either give you some information to test whether or not you've got adequate information, or might have some areas for improvement in your plan. And then for those of you obviously that don't have plans, might get some information to be able to develop plans. And then I think based on my discussion with Yvonne, we've put together the beginnings of a template preparedness plan that we may be sharing with you shortly after this presentation. So we'll talk about that a little bit too. So going forward, in order to manage this, you have to develop and then continually modify pandemic plans for your organization. And modifications necessary because you could see the degree of changes that have occurred in the guidance information and the knowledge based around the disease. It's going to be necessary to build up and maintain stockpiles of personal protective equipment and disinfectant materials in order to sustain organization activities. And then to complement that, the communities and states need to continue to improve the effectiveness of the screening and test sites in order to do their part in limiting the spread of the disease. And we also see that there's a lot of development in contact tracing, which has been determined to be an extremely important component of limiting the spread of this stuff.
Rafi, is that something that nonprofits should try to have at least one person that knows kind of the basics of contact tracing?
Well, there are some basics that we're going to talk about here as it pertains to at least the state of Pennsylvania and what the CDC recommends for contact tracing with respect to workers or volunteers who are around others who have become sick or exposed to or demonstrate symptoms, and what you need to do within your organization. But I'm not sure how that would apply to contact testing or contact screening outside of the workplace. So, but we will talk about how to apply that within the workplace. Okay, And you see the phases that we've gone through in Pennsylvania that are mirroring the CDC phase 1, 2, and 3 with in PA, the red, yellow, and green. And the major focus that we'll look at here is the green phase. And getting into that green phase has depended on some of that information that we talked about in the first slide, but things have changed. And the changes have been reflected within what the state's requirements are. Now that they're closing bars and restaurants in some counties, they're limiting how many people can go in. Within workplaces, you can have up to 75% occupancy, but you probably need to limit meeting situations to about 25 people now, whereas prior to this surge, you could have meetings of up to 250 people inside of buildings. So next slide. And then the basic requirements that we've talked about all continue to apply no matter what. That doesn't change because those are the basic things that you need to do to stop airborne transmission and dermal transmission that can potentially lead to the disease. As Frank had talked about with the hierarchy of controls, a lot of these practices are administrative-like controls, and the social distancing, washing hands, and things like that. But the limitation that puts PPE and administrative controls closer to the bottom of effectiveness is the variability in how human beings carry that out on a consistent basis. So that's the thing that is an important aspect of a preparedness plan, is monitoring the effectiveness of the practices that you put in place and to try to create corrections or reinforcements when you see deficiencies. So there are lots of informational guide sources out there, starting with the state of Pennsylvania. And there are the difference here, since most of, I think, the participants today are in the state of Pennsylvania, there are requirements there, whereas the other sources are mostly guidance, information, and non-mandatory. So we've got Pennsylvania, the CDC. Frank and I are members of the American Industrial Hygiene Association, and they've put out lots of information that we'll talk about for a few seconds. The World Health Organization, and then there are law firms like Fisher Phillips that provide some of the other side of this disease issues related to legal interpretations of what you can and can't do, human resources guidance when it comes to hiring people and dealing with Americans with Disabilities Act for vulnerable people. And then we've got the EPA that Frank has already mentioned that provides and continually updates lists of approved disinfectants. Before I show you some of these sources, maybe you're familiar with some of them, but I'd like to talk about some of the common components that you see across these guidance sources that make for decent pandemic preparedness plans. First off would be common components for COVID-19 management. And these are things that I've found over the course of my career that are important when it comes to establishing plans to implement programs for risk reduction. You really need to use a team or an individual that has ownership of the plan in order to manage this. And having a team or an individual probably depends on the size of your organization. If it's a larger one, it might be better to have a team where you have several people that can take ownership of different pieces of the pandemic preparedness plan. Whereas if it's a small organization, it might be easier for one person to do it rather than having a team. Obviously, you really should have a written plan for your business, a management plan that outlines responsibilities, who does what, the main areas of concern that need to be addressed, how they need to be addressed, who's responsible for making them happen, who's responsible for enforcing them, so that everybody kind of understands their role and what needs to happen within it. The management of the program needs to also involve training of employees and volunteers. Education is important for people to understand not only what the risks are, but what their responsibilities are in limiting exposure to themselves and their coworkers. And then the other big part of a good management of a plan is having regular evaluations of the effectiveness of your implementation. It would be half of the plan if you wrote it, implemented it, and then didn't evaluate how well it was working on a periodic basis, and then implement changes to make improvements where you see deficiencies. And then the final major portion of the management of these plans is creating venues and situations for listening to work employees and volunteer concerns and getting their input on the control efforts and how well they're working to aid in your improvement of the plan. Next slide. Okay, when we look at the common technical control guidance that you see across the different guidance documents, you see items like this. Work from home where possible. I mean, in the Pennsylvania rules, they stress and recommend work from home in the red, yellow, and green phase. And in fact, that's even switched within the last few weeks based on the uptick in Pennsylvania to, instead of we recommend that you continue telework, they say telework must continue where feasible. So it's a little bit more of a forceful use of that work from home, because that's a way of eliminating things. It eliminates exposure. It eliminates all of the additional risk that you incur by just being at work versus being at home. They include provisions for establishing social distancing in the workplace and or use of physical barriers. And when we talk about social distancing, it also includes staggering work start times and stop times so that you don't get a glut of people going in and leaving at the same time. It also includes looking at things like if you're in a higher rise building and you use an elevator, how is access to the elevator managed as far as the number of people that are on there at a time that are breaching or potentially breaching the 6-foot distance. Establishing surface cleaning and disinfection based on looking for frequency of contact of frequently used areas, frequently used equipment, and in the offices, like whether it's copy machines, staplers, central use of refrigerators, anything that is used frequently, door handles, and the like. They all include temperature testing of workers and visitors to make sure that you're monitoring whether or not people are coming to work sick. Making special provisions for vulnerable individuals. That'll come up whether it's people that have doctor's permission that they can't wear masks, or whether or not they're older individuals who might have risks like heart disease or diabetes that make them at higher risk that you need to potentially try to account for and maybe make some provisions for. Restriction of the use of break rooms and common areas and tools and equipment if you can. limiting access from visitors and only permitting them in through scrutiny. And we'll talk about that a little bit more too from some of the guidance that's out there. And training workers to stay home if sick and provide them the ability to do so. Using the what's called 6 foot, 15 minute, 48 hours rule, or in Pennsylvania, it's the 6-10-48 concept for contact tracing in the workplace. We'll talk about that a little bit more, but briefly, it's if someone becomes sick at work and has to leave, you then need to start having some concern about people that had contact with them at work. So you would be looking for individuals that were within 6 feet for 10 minutes or longer within the last 48 hours. And then they would need to be monitored for whether or not they see any symptoms starting up. And then actions would be taken depending on how that progresses. Most of these guidance also cover providing and requiring the use of masks. And as we know from the PA requirements, that is a requirement to wear masks at work. Promoting and advertising liberally the need for hand washing and providing sanitizer and making those materials available. Minimizing travel, if possible, maximizing fresh air changes that can be supplied through your heating, ventilation, and air conditioning system. And potentially, if it's possible, to add higher efficiency particulate filters within that system. And a lot of the guidance documents stress that if it's possible. And then the other thing that's necessary that's across the board is monitor these guidance sources for updates and changes. A lot of these are happening daily now. And then the other thing to consider is whether or not you can implement testing, and usually within an organizational environment, mostly that could come into play when it comes to permitting people back into work, but there are some drawbacks to doing that testing that we'll cover also. Next slide. This is just a snippet of the draft preparedness plan that we put together, covering the purpose and then defining the responsibilities. And then there are several sections below where you get an expansion of the plan control components.
And we'll go ahead and share that with you. We'll send that with the recording and the slides. So you will copy of the slides as well, and are recording this. So if you are would like to use this as a template, you'll get to see kind of all the sections. I know we're running out of time here, so I just wanted to let you know we'll be sending that out.
Yep, and it's based on a lot of those items that were in the previous slide, only stressing the definition of what goes in it, who's responsible for managing it, and what the employees are supposed to do with it. Mm-hmm. Next slide. Here are some of the links to the various informational sources. Yvonne, do we have time to bring any of these up, or should we just say these are ones that you can access and I can just say a few words about them?
Yeah, that's fine. I mean, I think maybe what we'll do is just go through the rest of the slides, and then we'll go back to highlight a few of these websites for those that are able to stay.
Right. Yeah, the important thing about the PA one is it outlines right now what the green phase requirements are, and monitor those for changes because they're happening. The second one is a CDC resuming business toolkit, which I think can be very helpful. It's like a checklist that goes through the different components and asks you questions about whether did you do this, is this in place, does it need further development. And then the main CDC business and workplace section gives guidance for small businesses and large businesses and various other types of businesses and organizations. Mm-hmm. Next slide. Just quickly, this is a summary of the requirements within PA for all phases. So there are requirements for doing cleaning and disinfecting of high touch areas, for managing if confirmed cases occur, for identifying and isolating employees that come in contact with a possible confirmed case. That's the 6-10-48 rule. Temperature checks, preventing large groups from entering or leaving the building through staggering, work start and stop, conducting meetings virtually if possible. And this still has the old number of 250 people if you have green phase, but that's down to 25 right now. Providing access to soap and water for hand washing and all the other disinfectant materials, discouraging non-essential visitors, and communicating procedures to workers. These are Pennsylvania requirements, okay? If you're not in Pennsylvania, they may not be requirements for you. Next slide. Then we have OSHA guidance. OSHA has provided guidance also. And there they talk about risk levels, high risk individuals, moderate risk individuals, low risk individuals. I would say, based on looking at those definitions, most organizations, unless you're working with infected people, are probably going to be at the low, between the low and the mid level. They also provide guidance for specific business sectors. But one thing I want to reinforce on the OSHA side is if your organization employs 10 or more people, you're required to do injury and illness record keeping and turning that information into OSHA. And in those circumstances, they have required that you record positive COVID-19 cases if they are work-related. So there is guidance on that OSHA page that tells you the specifics there. We've lost the slides. Slides aren't up.
Oh, the slides aren't up?
Yeah.
I'm going to go to the websites, if that's helpful. You see the websites now?
Yeah. It looks like we're on the AIHA website, and they've put together, if I can page down through this. Can I page down?
I think so. Let me see.
Oops, World Health Warden.
Is it working for you?
I'm on the World Health Organization one now.
Okay.
I would say, the World Health Organization has similar information as you see on CDC, but it's a little bit more general because it's worldwide application and not US based as much. So I would use that as a secondary source of information if you wanted to, and look to the OSHA, AIHA, and CDC as your primaries. Can we bring the AIHA one up? I don't know which one it is up there.
Is it back to work safely?
Yeah.
Yeah, here we go.
And if we could page down through that a little bit, down towards the bottom, you see it's got guidance, specific guidance for lots of different areas: general office setting, construction, hair and nail salons, libraries, museums,
yep.
That they try to customize a little bit of the guidance to the kinds of risk situations that you get into, those situations that could potentially help you in refining existing plans or in developing plans. So that's what I like about the AIHA one. It doesn't get into specifics because it doesn't know what your very specific issues are, but it's refined a little bit. The same for the CDC. You see some specifications there. They've differentiated between small businesses and large businesses, and then also they give you guidance by specific work areas. And then if you page up a little bit, they have a link on the left here to the toolkit. See where resuming business toolkit, it's a little bit down now.
Here it is. Yep.
This is, I kind of like this if you want to check what you've done against it, or if you're developing a plan. If you page down, you get to the actual checklist. We'll just show the first part of it. So where they're asking, you're saying, here's an item, is it complete, ongoing, not started, or not applicable? And it goes through all these different areas of concern with related to risk that might help you in determining whether or not you've adequately covered some of these applicable areas. And then they've also got one down below related to the hierarchy of controls and how you might apply them. If you go down a little bit further.
There's maintain a healthy work environment.
Yeah. So I like that idea of a checklist. And then here's your worker protection. You can check off ones that are potentially applicable. One important thing you see here in CDC and OSHA is you do a hazard assessment by the type of activity that you're doing. So you might have an application of the controls to limit airborne exposure and dermal exposure in an office that might be different from a different set of activities that might be happening. So each one of them should receive some level of a hazard assessment in order to fine-tune how you address and apply the controls to those situations. So that's those. And if we could go to the Fisher-Phillips ones, the PF ones, the first one, the first PF, the first one. There we go.
Yeah. Is this it?
No, then let's try the next one.
This one?
Yeah, this is questions and answers on lots of different areas with regards to how you legally manage this COVID-19 issue, and kind of takes you a little bit outside of just the health and safety side. But now, what are my legal limitations and obligations? What limitations do I have from a human resources perspective when I'm dealing with people that come, vulnerable people that come forward with saying, I can't wear a mask, or I've got diabetes and I'm 70 years old and I might need some additional accommodation. What are the legal requirements? There are tons of questions and answers there in these sections that might help you find sources of information or educate you more on how to deal with that stuff if you need to. If you go to, go ahead.
This one was interesting with, according to CDC, you should only consider, you should consider 3 questions when deciding whether to reopen. Are you in a community no longer requiring significant? Will you be reopening in compliance? That one's easy to figure out. And then will you be ready to protect employees at higher risk? And you should only consider reopening if you can answer yes to all 3. And
right.
That's tricky. That's hard.
Right, and then you see the hazards of not following that over the last month across the country. So, but I thought this was very good for providing those types of answers. This one is a posting that you could put on a door for visitors that says, here are the qualifications that you have for potentially coming in here. And it has to do with, have you had any close contact with somebody who has been infected within the last 14 days? Have you traveled to restricted areas? And now that can be extended, at least in Pennsylvania, to lots of states. And then do you currently experience or display or have not had within the last 14 days symptoms? And then if they answer no to all of those, they're candidates for visitors that might come in. And then outside of that, you might just limit visitors to the people that absolutely need to be in there. And some of this visitor management has to do with delivery people and pickup people, like from FedEx and UPS or United States Postal Service or Amazon. What happens? Do they drop things off outside? Do you have an isolated point for them to pick materials up and not permit them to come inside buildings? And then this is just another CDC site that provides updated information. It might be helpful. It provides updated information beyond just COVID-19, but also for COVID-19. Okay, so that's basically what's there. And these guidance sources are to help you. I would think something like the preparedness plan template gets into the specifics. The template that I put together focuses more on the health and safety aspects, but if you want to, you can add other sections to that covering what your leave policies are, how to manage workers with vulnerabilities, how to manage contingency plans for how your organization functions if you have a large number of people that are out sick, which is a possibility with this. People get a cold and they're probably going to stay home now, even if it's not COVID-19. So you may end up with more absenteeism, and how would you manage that? So I would look to the template and then the guidance sources as information to help you understand the kind of information to put into the template sections. And then obviously you need to pay close attention to the Pennsylvania requirements that you have to comply with. So that's basically it on that. We could probably end it at this point if you want to, because we're kind of way over.
Does anyone have some questions they'd like to ask? I know we can't answer everything. I know that I just want to thank you for your time, not only sharing with us this morning, but putting all of it together and just really thinking through how we open safely and how we keep not only our employees safe, but the people that we're working to support and help through this crisis. So many of us are on the front lines of helping people that are directly affected by this disease, as well as directly affected by the economic impacts of this pandemic. I see many of you are on the front lines, and I'm so thankful to all of you. Great. And I will be sending out the information that will have all of these links. There's actually even more links than we've already highlighted or previewed. But again, I recommend that you, if you have not already, subscribe to some of those. I looked at the EPIC newsletters. There's ways to keep in touch with what's going on. Again, you know, Rafi and Frank told me about the 6-10-28 rule. I had not heard about that. So again, those keep getting changed daily. Well, not daily, maybe daily. I know that the US had a 6-15-28. Pennsylvania changed that. I was talking to another friend who works with a large human service organization just this morning, and he said there's more outbreaks in places that have not just nursing homes, but care facilities for people with intellectual disabilities. And just as we watch all of that we have to all be nimble to continue to watch what's going on at the state level and what's required of us. And so just applause to all of you. So any additional questions? Otherwise, we're going to say thank you and keep going on with our days. So thank you. Thanks so much.